Monkeypox is a viral zoonotic infection that is endemic to certain parts of Africa, and it's characterized by development of this flu-like illness followed by development of a rash. And this rash is similar to the rash that we see in smallpox. The only difference is smallpox used to be more lethal and more infectious compared to monkeypox. Now, smallpox and monkeypox belong to the same genus of viruses known as orthopox. So if we look at these agents under an electron microscope, they're going to have very similar structure. They're going to have this brick-like structure. Now, there are two strains of monkeypox. We have strain 1 known as clade 1. This is the more virulent that is endemic to parts of Central Africa, such as, for example, the Congo. And then we have the less virulent second strain, so clade 2, that is endemic to West African countries. Now, the first case of monkeypox was actually isolated from monkeys, and that's why we call it monkeypox. So, this was isolated in 1958. So in 1958, a bunch of monkeys were sent from Singapore to Denmark. And the purpose of those monkeys was to use the monkeys to study the polio virus, the polio infection. But those monkeys became sick, and when we tested those monkeys, that's when we isolated and identified the monkeypox virus. So that's why we call it monkeypox. But monkeypox is actually a misnomer because monkeys, as well as humans, are not natural reservoirs for this virus. So what exactly is a natural reservoir? Well, natural reservoir is an animal that the virus needs to actually reproduce. The natural reservoir, we don't know what that is, but we think they're rodents in Africa, so either rats or mice or squirrels. Incidental hosts are animals or humans that become infected and now have to suffer from the virus. But the virus doesn't use incidental hosts to actually reproduce as the natural cycle of that virus. So 1958 was the first infection in animals that we know of, and the first infection in humans was in 1970. So basically all this time we found other cases in other animals, but in 1970 was the first time we actually found it in humans. And so there's a child in the Congo that became infected with monkeypox. And the way that they got infected likely was from transmission from an animal to that human. So either because of a bite or because of direct contact with a lesion on the skin of that animal, or maybe bodily fluids of that animal. Now, from 1970 to 1980, there were about 59 cases that were found in humans in Africa. And all of these cases were thought to be transmission from other animals. Now, in this time frame, we were also eradicating smallpox. So we basically came up with a vaccine. We're vaccinating the population with that smallpox virus vaccine. And that smallpox vaccine actually also worked against monkeypox. And so that's why we saw so few cases. Now, 1977 was when we completely eradicated smallpox. And in 1980 was the last time we gave the smallpox vaccine. And since stopping the smallpox vaccine from 1980 to early 2000s, we started to see a rise in the number of infections of monkeypox in humans. And that's likely because we discontinued the use of the smallpox vaccine. Now, the first time we saw an outbreak of monkeypox outside of Africa was in 2003 in the US, and that was because of imported animals from Africa. Then we saw an outbreak in Nigeria, then we saw outbreaks in UK in 2018, and in 2021 in the US and in the UK there were outbreaks. And now there are outbreaks in Europe and the US in 2002. So let's talk about transmission. Again, we don't know exactly what the natural reservoir is, but we think it's rodents living in Africa. So rats, mice, squirrels. Monkeys and humans are not the natural reservoir. These are incidental hosts, meaning the virus doesn't need humans and monkeys to actually reproduce, but they can infect these species. So in terms of the most recent outbreak in the US and Europe, how do we become infected? So there's human-to-human contact to cause infection. So we can become infected via direct contact, and this is by far the most common mode of transmission. So direct contact of a non-infected person with an infected person who has infected lesions. And this likely takes place because of sexual intimacy. So, in fact, 98% of the cases of the current outbreak of the monkeypox virus happened in men who have sex with other men. We can also become infected indirectly via contact with clothing or linen that were exposed to lesions. So, for example, if an infected person sleeps in a bed and then you sleep in that bed, there's a chance you may become infected, so you're exposed. There's also a chance that respiratory secretions could cause an infection, but here we have to have prolonged face-to-face interaction with that person, and those respiratory droplets have to be pretty large. And finally, vertical transmission. So if a pregnant female becomes infected, then the virus can transmit via the placenta and infect that developing fetus. And that can increase the risk, for example, of fetal complications and malformations and miscarriages and stillbirth. Now, a person is considered to be infectious from the onset of symptoms to the point where all the lesions basically are scabbed off and fall off. So let's talk about the clinical presentation. So the majority of cases of infection will lead to symptoms. There's only one single case during this current outbreak where a patient became infected but did not have any symptoms. So the majority of cases are symptomatic. So if you have an infection, you will present with symptoms. Now, the incubation time is about 4 to 21 days, meaning that it may take anywhere from 4 to 21 days from the time of exposure to the time of actually feeling those symptoms. Now, in many cases of monkeypox, patients have a prodromal phase, up to 5 days. So meaning the first thing they begin to experience is a flu-like illness. So they may present with a fever, so a high temperature, chills, malaise, so they're feeling overall unwell, fatigue, they may have a severe headache, they may complain of myalgias, meaning muscle aches, and lymphadenopathy, so enlargement of the lymph nodes, and these lymph nodes may be localized or more systemic. And this flu-like prodromal illness may take up to 5 days, or may be symptomatic for up to 5 days. About 1 to 4 days after experiencing a fever, that's when they develop a rash. Now, the rash is characterized by these lesions. We can have a few lesions or hundreds or even thousands of lesions on the body. Typically, it affects the face, it affects the soles of the hand, the palms of the hands and the soles of the feet, but it can also affect the extremities as well as the genitalia and even the rectum. Initially, the lesions are macular, so they're basically flat lesions, so we basically don't feel any bumps. But eventually, they become raised, and so we will feel bumps. And those raised papules can then turn into vesicles and pustules. And so these can resemble the rash that we see in varicella zoster infections, so shingles, as well as herpes simplex virus infection. So these can be very similar. Over time, they will crust over and fall off, but this can take up to 2 to 3 weeks to actually take place. Initially, the lesions are painful, but eventually they become painless and more itchy, so more pruritic. Now, interestingly, in the most recent outbreak in 2022, some people never actually developed the prodromal phase. They just simply developed that rash, and that rash can take weeks and weeks to actually clear up. Complications. So complications are rare. And the only time we really see complications is if the infection is severe enough and it happens in immunocompromised patients. So in children below the age of 8, in immunocompromised patients, as well as patients with other skin diseases such as, for example, atopic dermatitis. So what are immunocompromised states? So HIV infections which aren't treated, as well as patients with solid organ transplants, patients that are taking immunosuppressive medications such as steroids for other conditions, patients who have leukemia, so cancers of the blood or lymphoma. All of these patients are immunocompromised. And so if they develop an infection, they are at risk for developing severe cases as well as these complications. And what are the common complications? Well, secondary infections. They can be secondary skin infections, lung infections, so pneumonia, bloodstream infections that can cause sepsis, brain infections known as encephalitis. How do we evaluate patients and diagnose patients presenting to, let's say, the hospital with monkeypox? So we can get basic blood work, but the blood work may show non-specific findings. So maybe an elevated white blood cell count, leukocytosis, that just means we have an inflammatory process, an infection taking place. Transaminitis, so elevation of liver function enzymes, can also be found, as well as thrombocytopenia, so low platelet count. Now, who do we suspect infection in? So suspect an infection in anyone with typical findings such as a rash and a prodromal phase, as well as an exposure to somebody with a known infection. The way that we test is we take a swab of that lesion and we test via PCR. We can also get serology labs, so IgG, IgM, but this can take days to weeks to actually become positive. So just because this is negative doesn't mean that the patient is not infected, because it takes a time to get IgM, immunoglobulin M, and immunoglobulin G to actually become positive. So this is a marker of a recent infection. This is a marker of a more distant infection. Treatment. Luckily, in the majority of cases, we don't actually have to treat the patient, because the patient, for the most part, will become that infection, for the most part, will be self-limited, meaning our immune system will have no problem dealing with that infection on its own. It's just going to take time. And in most cases, it's just supportive care. So if the patient feels nauseous, we can give them anti-nausea medications. If they're dehydrated, we can give them fluids. But in some cases, especially in the immunocompromised population, in children and in pregnant patients, we actually can treat with antiviral therapy. And currently, the first-line treatment for monkeypox is a medication known as tecovirimat. So tecovirimat is an antiviral medication that blocks a protein known as F13. So this is a viral envelope protein, so it's a protein found on the envelope of the virus that is needed to infect cells. So if we have an infected cell, and here we have a nearby healthy cell, so the virus infects this cell, it propagates in the infected cell, and then for the infected cell to spread it to this healthy cell, we have to have this F13 protein. And so what this antiviral does is it blocks this protein, and so ultimately blocks the infected cell from infecting other nearby healthy cells. So generally, this is a weight-based antiviral agent, and we give this for 14 days. And we give it only in specific cases, generally in the immunocompromised, in children, and in pregnant individuals. What about exposure? So if you're exposed to somebody with known monkeypox, then you have to basically watch for symptoms for 21 days, because the intubation time is up to 21 days. Now, in that time frame that you're monitoring yourself for symptoms, you could do whatever you want to do. You can continue your daily activities of living. But if you develop symptoms, any of these findings here, you have to self-isolate yourself for up to 4 weeks, because that's how long it can take for those lesions and that rash to actually fully clear. What about post-exposure prophylaxis? So if you are exposed to somebody with that monkeypox virus, should you become vaccinated? Well, it actually depends. So the CDC breaks down post-exposure to high risk, intermediate risk, and low risk. If you're low-risk exposure, you don't have to get vaccinated. If you're intermediate, it's a case-by-case base. But if you're high risk, they do recommend becoming vaccinated with monkeypox. The vaccine is the MVA vaccine that is given against smallpox, but it also works against monkeypox. And so it's a 2-dose vaccine that is given 4 weeks apart. Now, generally, if you vaccinate the person who's exposed within 4 days, that may actually prevent infection from occurring in the first place. But if you vaccinate them within 4 to 14 days after exposure, this can actually decrease the severity of those symptoms altogether.